Okay, I'm not sure if you're able to dim any of the lights above here at all. It might make the videos a little bit easier to see. I'll leave that. So thank you for inviting me. TOE in the cath lab is getting more and more challenging for us that deliver it, and hopefully by the end of this talk you'll start to feel sorry for me. No conflicts of interest. Some of these images I haven't actually been specifically involved with, so my thanks to the team that have been acquiring some of these images, and all the people that actually work in the cath lab with me. So going into the cath lab, this is quite a common indication to go in and have a look, hunt around for clots. This is mainly for the EP procedures. A lot of ablations nowadays are done without sort of anticoagulation cover. So although this is unlikely to be found, this extent of clot, but it's not uncommon to find smaller things floating around in the left atrial appendage. And again, I do request that the lights go down a little bit because they're very, very bright on the screen. So I hope you can all see the little tiny clot bobbling around in the left atrial appendage. So that's quite common for us to go in and sort. This is a very unusual finding of a clot in transit that's actually stuck in a PFO. But again, you will get the odd surprise when you're looking for clots. However, most of the talk is going to be about TOE for the interventional cardiologist, and I will basically take you through vignettes of various interventions that we personally are involved in at Wythenshawe Hospital in Manchester, which will include TAVIs, ASDs, a bit of Mitra-clip, some perivalvular leaks, and the left atrial appendage closures. So, talking about TAVI, there are basically two types of valves, percutaneous valves, that are available commercially. One is the self-expanding Medtronic core valve, which is kind of hourglass shaped. There's bovine pericardium in the middle. The valve actually sits supra-annular, so the valve sits about a third of the way up in the mesh. And the other valve, which I personally don't have any experience with because a lot of these centres actually are either core valve centres or Edwards Sapien centres, because they gain a lot of confidence in one technique and don't really like to sort of diversify too much. It's just the cardiologist, I guess. But this is a balloon expanded valve, so it comes in like a little stent and you actually put a balloon through it to expand it out. This is what a core valve looks like in animation. So a core valve is put in through a femoral approach at retro-aortic and goes and sits in the aortic valve, and very gradually opens up the mesh, starting at the LV outflow tract and then moving up. The Edwards Sapiens looks a lot simpler, but I'm told that it's actually very, very difficult to actually get it into the right place. But you go straight into the landing zone and blow up the balloon to expand the valve. Now, the role of the TOE is not only to actually assess perioperatively for the procedure, but also to make sure that you are actually doing the right kind of people. So you would go through your severe AS kind of algorithms. Core valves, or TAVI valves in general, are done for AS rather than AR, but you do have the odd patient with aortic regurgitation as well. So assessment of the severity of these valves is important. TAVI sizing is critical to this procedure because this is actually usually done preoperatively, but perioperatively when you've got somebody with a GA and you can manipulate the probe better, the sizing of the annulus is actually very, very important. Now this annulus, it would not be a core valve candidate, but it's very, very easy to see without any calcium. But that annulus actually is quite difficult. So the annular sizing can often be done and should often be done by 3D measurements, so we can actually measure across the field properly rather than obliquely. Now, the sizing is important because once you actually size the valve, then you can choose what size of device to actually load up on your catheters. Edwards has 3 valve sizes, and the core valve actually currently have 4. The smallest size that you can actually put a core valve across is about 18 millimeters, and the biggest being 29 millimeter annulus. Now, for deployment, this is a picture I love to show. Just watch this mitral valve completely stopping as we deploy a balloon doing the valvuloplasty. It just shows you what's happening in the left atrium when there's complete blockage of blood flow. It just completely fills up with spontaneous contrast, and again, hopefully you can see that. This is a core valve just starting to be deployed, so there's a big catheter up the aorta, and a little bit has come out. Can you just make out that there's a V-shaped prong coming out? So the LV outflow tract, getting a little bit bigger now, a third of it has been deployed, and finally the full deployment. Now, if you have a tri-leaflet valve, your core valve usually has quite a good result, but if you have bi-leaflet valves, you can end up with a core valve looking like this post-deployment. So dilation within the valve is actually quite common. So post-dilatation, an example here of a core valve already sitting there in the balloon dilatation, so valvuloplasty of a core valve to make it into a better shape. That can cause complications, which I'll show you in a minute. The complication rates in general are not really seen on TOE because the biggest complications actually happen with the access routes. So the vascular complications are 30% of patients. They can be quite horrific. Vascular surgeons are usually on standby to come and bail people out. 20% need pacemakers, 10% have CVAs, and this is all patients, but with the aortic TAVIs that we do. But these are some of the complications that I will show you, and these can be, seen on TOE more than on fluoro. Here's an example of a floating blob of calcium after the core valve has been put in. Now, that obviously has the danger of going down a coronary artery, so what we tried to do usually is, rather than do anything with the first core valve, is to try and block the calcium with a second core valve, so valve and valve, okay? So this particular patient actually didn't have any problems with that blob of calcium, but this particular patient actually has calcium down the coronary, so this can be quite catastrophic, and this patient actually didn't make it out of the cath lab. This is quite a fantastic view of thrombus that's formed within the catheter. They tell me that they flush it properly, but clearly not. So thrombus floating around everywhere. And on the next view, you'll see a thrombectomy catheter that's got suction added on at the end, gradually getting rid of the thrombus. And amazingly, the thrombus actually goes down the thrombectomy catheter rather than flying off somewhere else, but that's a problem. Migration of a core valve acutely can happen. This is migration into the LV outflow. This is migration of the same valve into the aortic root, because a surgeon has then snared at the top end of the core valve and pulled hard, but pulled a bit too hard. And then you actually have to guide the whole thing back inwards, which is a lot of pushing and pulling going on in the core valve lab. So it's very brutal, almost orthopedic type of procedure, really. This is another fatality that we've had. By the way, we have done quite a number of cases, so I'm showing you some of the complications, but don't be thinking that that's what happens in every case. So our institution has done about 250 cases, and we've had fatalities in 3 people. So this is a fatality that actually was caused by post-dilatation. So this is a core valve that the interventional cardiologist and the echo, we weren't happy with the AR that was being left behind. Some AR, paravalvular AR, is very, very common, but degrees of AR are not acceptable. So then the valve was dilated up with slightly vigorous ballooning and caused quite an acute and catastrophic tamponade with blood and clot, basically, in the pericardial space that could not be excluded quickly enough. So moving on to paravalvular closure devices, I'm not sure if any of you have witnessed these in the cath lab. These can take a long, long time. You have to be very patient in the cath lab. But basically, you can put devices into, generally the paravalvular leaks are on the mitral valve. This happens to be a mitral bioprosthesis. I personally don't have any experience of paravalvular leaks that are closed in the aortic position, but some experience in the mitral position. This is a mitral valve you can see beautifully on 3D that's just bouncing in and out through the annulus. And you can actually put, 3D is very, very important in localizing the color jets, so you can actually see the paravalvular leak through color jets coming out into the left atrium. The devices that get put in are tiny little apple cores, effectively. This is an Amplatz plug, and this is the finished product with 2 plugs on either side, looking from the left atrial view. So a lot of this is actually done by 3D. So you identify the paravalvular hole. With 3D guidance, you actually guide the interventional cardiologist with their catheters. And this actually shows you how beautifully visible catheters in general are on 3D and TOE. So you guide them towards the hole, and then you guide the procedure of the actual implantation. This is a device that's obviously not anywhere near the mitral valve. This was actually next to the mitral valve, but they were trying to get a second device in because there was still a lot of residual MR. People are nodding, so you've obviously seen some of these things. And by wiring the hole next to the original device, this device actually flew off into the left atrium. Now, interestingly, the interventional cardiologist didn't go chasing after this one because there was nowhere for this device to go. So it was stuck in the left atrium. There was still quite a lot of MR coming back, so it kind of fixes the device towards the back wall. And so 2 more devices were actually put in there before the retrieval of the first one. And this is on TOE that you can actually see the device floating around the left atrium. So for that particular patient, there was a combination of a snare device, which then transferred onto a basket device. And this is the basket taking it out from the contralateral leg. But you can still see that it's actually not suitable to come out through the catheter. So you do have to do a lot of manipulations, and often the vascular surgeons come and help us with this, or the interventional radiologists come and help us with this. So there's the device finally being squished into a catheter and being taken out from the other leg. Left atrial closure devices, the animation will be self-explanatory, but basically left atrial appendage with a parachute, effectively, with nitolol prongs that basically sit there. You do a tug test to make sure it doesn't come out. You put contrast in to make sure contrast doesn't go back into the left atrium. And hey presto, you've got a nice device in situ. There are lots of devices around. I have most experience with the Watchman device, but there's an Amplatz. So this device is actually now being taken out off market. So I'll show you a Watchman device going up. So here's the left atrial appendage from one of the views that was shown to you in Scott's lecture. So this is a device going up, and this is a tug test that's failed. So the device has come out again of the left atrial appendage back into the left atrium. So another nice thing about this device is that you can actually do the tug test and everything squishes back in quite nicely back into the catheter. So you can go back in with a bigger device. So that's exactly what's happening. And a bigger device sits in better, and this is a tug test. You'll see the whole thing trying to be tugged out, a tug test that actually passes, so you can let go of the device. ASD PFO closures have been going on for a heck of a long time now, so these are fairly routine bread and butter stuff for the interventionist. But in general, the secundum ASDs are closed with nice simple holes that are not too big. 3 centimeters is probably the biggest device that we can deploy with an Amplatzer procedure. But effectively, this is what's happening. You go up the leg, across the ASD, which is very, very easy to do, and you get the left atrial side of the umbrella up, and then you pull hard until you are flush with the ASD. You check that it's not going to come through before you deploy the right atrial side of the umbrella. And then you have to check that the septum has actually been caught between the two pieces of the umbrella, the two sides of the umbrella. And this is what it looks like on TOE. And you basically have to do lots of checks to make sure that all around the margin, the ASD is actually, the device has actually been caught properly around the septum. ASDs don't go wrong, touch wood, that frequently, but this is one that 3D was extremely helpful because they put a wire across the ASD, seemed to go in beautifully. They put a balloon up, so that dilated up beautifully, but somehow the device wouldn't deploy properly. So when we actually looked at it on TOE, everything looked fairly simple, except that there was a very, very floppy septum, which makes life very difficult for ASD devices. But when we looked on 3D, you could tell that the ASD had actually, so the ASD was still there, but the catheter was actually pointing through a PFO tunnel rather than the ASD itself. So 3D is very, very helpful in giving you a different perspective, so you can pull things out and go back in the right places. The latest challenge for us in the cath lab, and Wythenshawe is actually one of the 3 centres that are delivering Mitra-clip, so certainly we're having to deal with this challenge absolutely imminently. And the Mitra-clip procedure is basically a percutaneous version of an Alfieri stitch, which is done by a device. So again, we go up the leg, cross over the septum, and we put a clip between usually A2 and P2 to give you a double orifice mitral valve. And you can have, apparently, there's a centre that's put in 7 clips in a patient. I'm not entirely sure if the mitral valve can take 7 clips, but obviously a very big mitral valve, but that's the record at the moment. There's about 22,000 cases of this that have already been deployed, mostly in the US, but Germans have been very prolific in Mitra-clips. Their financing systems are different, their healthcare systems are different. But we are actually not funded for this up until about October, when the funding in the UK was made available only for 3 centres. So we're very, very privileged at Wythenshawe to have been chosen for this. TOE is absolutely vital in assessing the anatomical suitability for a clip, but this should not be happening in the cath lab, so you shouldn't be getting to the cath lab with a Mitra-clip case without doing all these assessments. So the TOE assessment preoperatively is vital for Mitra-clips. But perioperatively, it is basically a TOE-led procedure. So fluoroscopy is still used, but if you speak to people that have been doing them for a long time, they use less and less fluoroscopy as they get better and better at their procedure. So initially in the learning curve, you might use 30 minutes of fluoroscopy, but you speak to people that are high volume, do high volume cases, they're only using 2 minutes of fluoroscopy just to guide things up and down the legs, for example, and nothing more. So this is a bicaval view similar to what you've seen, and the septal puncture has to be very, very accurate for this procedure, otherwise it doesn't actually land in the right place. This is a device coming down the left atrium, further down towards the mitral valve, and finally with open arms across the mitral valve. 3D is very, very important because if that's the mitral valve smile, you need to know exactly where your leaks are and where you want to actually land. So you need to be perpendicular to the coaptation zone. So that's a clip that will be going across in the ascent of the smile, whereas this is a clip that will be going exactly on P2 and A2. And this is the grasping of the leaflets that are grasped within the little clip. And finally, the deployment. So there's no catheters attached, so it's already been deployed. You never really get rid of the MR completely. This is not a surgical option. So there is always some MR left, like there is in TAVIs, in core valves in particular, but you end up with a double orifice. Fairly recently, we had a clip embolization into the right upper pulmonary vein. You can actually just see that there, hopefully. This is on 3D. You can see that they've managed to actually guide the catheter close enough to that embolized clip, and a snaring device from the leg to try and grab the clip from the right upper pulmonary vein, align it. There are actually 2 snares used in the end. Align it and finally pull it down. So just to finish off, TOE requirements are getting more and more prolific in the cath lab, from simple things to very, very complicated things nowadays, and it's getting very, very challenging for the ones that are delivering. So wish me luck. Thank you.